the School of Pharmacy. So I'm going to talk today about SGLT2 inhibitors, which is sodium glucose cotransporter 2 inhibitors, and the incidence of diabetic ketoacidosis. So just as a review, SGLT2 inhibitors were first started to market in 2013, and I've got them all listed here for you. They include canagliflozin, dapagliflozin, and empagliflozin. And I also listed the brand names as well as the combination forms that are available on the market right now. So when these were released, they were very exciting to prescribers and patients because this gave another oral medication that could be used in patients with type 2 diabetes prior to moving to things like insulin and injectable therapy. So it's really exciting when they were introduced to the market. Another exciting thing about these medications is the novel mechanism of action that they have. So the way that they work is independent of insulin resistance, and it's also independent of beta cell function. So this is very beneficial in type 2 diabetic patients, and it also allows them to be used in type 1 diabetic patients, is what we're finding, that their mechanism does work in those patients. So real quick, I just wanted to review the mechanism of action. Most of you have probably heard of them before and know a little bit. In normal physiology, glucose is filtered by the kidney, and then it's then reabsorbed back into the blood through SGLT2. And then SGLT2 reabsorbs about 90% of the glucose in the urine, and that's done in the proximal tubule. So when we use SGLT2 inhibitors, we inhibit that channel, and that allows us to increase glucose reabsorption, to inhibit glucose reabsorption and have more glucose excreted in the urine, and that reverses hyperglycemia. So that's kind of how these medications work. Some benefits of this medication: it decreases A1C between 0.5 and 1%. It decreases both fasting and postprandial blood sugars. And we also see in many patients a decrease in blood pressure as well as a decrease in weight. So those are all really good things about this medication. Some side effects that we see are UTI, we see yeast infections, as well as balanitis. These are all due to the increase in the glucose in the urine, causing more bacterial growth. Is why we see those things. And another side effect is hypertension, because like I said, sometimes the blood pressure lowering effects can be significant. So that's kind of an overview of SGLT2 inhibitors. And on March 15th of this year, 2015, the FDA released a warning saying that SGLT2 inhibitors may be causing DKA in patients with diabetes. So real quick, I wanted to talk about what DKA is, just so we have a little bit of a review. So usually we see DKA in type 1 diabetic patients with extremely elevated blood sugars. That's our normal presentation. And this happens due to a decreased amount of insulin, which allows the body not to be able to use the carbohydrate sources that we have. And due to a lack of ability to use those carbohydrate sources, the body goes to other places to find energy. And so often it breaks down muscle and fat tissue, as well as producing more glucagon. And this causes an increase in the amount of ketones, which is the breakdown product, in both the blood and the urine. And that's kind of how diabetic ketoacidosis works. And we're used to seeing this with very high blood sugars in patients with type 1 diabetes. So this new type of DKA that we're seeing is actually a euglycemic DKA. And euglycemic means that it's a near normal blood sugar. And that's what we've seen with most of the cases of DKA with SGLT2s. Some similarities with euglycemic DKA as compared to the DKA we're used to seeing is a lot of the same signs and symptoms. So we see difficulty breathing, nausea, vomiting, as well as just some of the confusion and abdominal pain and fatigue that we're used to seeing. Some things that we see with type 1 diabetes DKA is fruity breath, and that's not been observed with DKA that's seen in patients using SGLT2 inhibitors. And we also don't see as much of the polyuria and polydipsia in these patients. Some other things that I wanted to mention were some of the triggers that have been noted. These are also very similar to stuff seen with hyperglycemic DKA. So major illnesses can be something that triggers this DKA, as well as reduced food and fluid intake is a big thing, and reduced insulin dose, as you can expect from the mechanism of DKA. We also see that infection can be a triggering factor. Some of the case studies reported UTI, gastroenteritis, and influenza being things that cause DKA in some of these patients. And we've also seen that it can happen after operations. And so that's something that's being looked further into, is when should we stop and restart SGLT2 inhibitors in relation to operations. So this next figure on the bottom shows a little bit about how we differentiate and why we see euglycemic DKA in patients with SGLT2 inhibitors. So we do still have an insulin deficiency and an increase in insulin resistance in patients who have euglycemic DKA, but it's not as great as that seen with DKA in type 1 diabetic patients. The fact that this is milder still leads to glucose overproduction and an underutilization of glucose, but again, it's to a lesser extent than that seen with DKA. So through this, we see an increase in glucose, but since we have the SGLT2 inhibitor on board, it causes twice as much glucose excretion in the urine, therefore the blood glucose returns to normal. So that's kind of why we see the normal blood sugars anywhere has been reported in the 90s, as low as in the 90s in these patients with DKA. That's why we see the normal blood sugars rather than the extremely elevated blood sugars. So the reason that I wanted to talk about this today, I feel like it is a very challenging thing both to outpatient and inpatient clinicians, because this is not a typical DKA patient. So I think we need to be able to identify it and see it. I'm going to talk a little bit about the data that is out and the cases that we've seen with DKA. So the FDA in March released their warning, and as part of this warning, they said that they've seen 20 patients between March and June that had DKA, that's euglycemic, associated with SGLT2 inhibitor use. All of these cases, all 20 of the cases required either an ER visit or hospitalization, and they were all diagnosed by a healthcare professional. They also said that most of these cases were with type 2 diabetic patients, although they haven't reported a lot of the information specific to these cases. They did report some of the triggers, similar to what I mentioned previously, but they did also say that half of the cases did not have an identifiable trigger. The European Medicines Agency also, in May of 2015, also released some data, and they said that they've seen a total of 101 cases of euglycemic DKA with SGLT2 inhibitors, and that's worldwide. But in their report, they didn't say much about any of the circumstances of when these happened. They didn't say much about the patients or any of their triggering factors in that. There was a case study by PharmD that was released in Diabetes Care this month. And in this case, they analyzed a database of over 17,000 patients with over 24,000 patient years of use of the drug. And most of these patients were suspected to have type 2 diabetes. Out of all of these patients, they found 12 patients with 13 cases of DKA. And of these 12 patients, after further looking into them, they actually diagnosed 6 of them with latent autoimmune diabetes and type 1 diabetes. So after looking further into it, they didn't all end up having type 2 diabetes after all, which puts them at an increased risk of DKA to begin with. They also in this study reported the blood sugars were actually elevated. This is actually the only thing I found where the DKA with SGLT2s was found in patients with elevated blood sugars. Another case report by Peters, it was in the same issue of Diabetes Care, found 9 cases of DKA with SGLT2 inhibitor use. 7 of these patients were type 1 diabetic patients and 2 were type 2 patients. And in this study, 2 of the patients had this DKA after alcohol consumption, and 3 patients, they re-challenged the drug. And after re-challenging the drug, the patients had DKA a second time. So definitely this supports us not re-challenging in these patients. At least those 3 patients showed that. And in the 2 type 2 diabetic patients, both of these episodes were found post-operatively. One had had a colonoscopy and another had a cervical surgery. So with all of this information that we found, most of the cases have been seen in either type 1 patients or in type 2 patients that are treated with insulin, is the majority of what we've seen in these reports. The treatment for this disease is very similar to DKA, how we generally treat DKA. The only addition that we found that needs to be done in these patients is adding glucose, because if we're giving them IV insulin, then we obviously need to treat with glucose since they are euglycemic in these cases. So we need to make sure that we add that glucose to their treatment. So implications for all of us, I think, are really important. So I do think we should still use SGLT2 inhibitors. I don't think that side effect is anything that should keep us from using these drugs. I think they're still very beneficial in type 2 diabetic patients, seem to have great outcomes, and have been proven to last over the long term, have lowered A1C. I do think at this time it is something to think about whether we should use them in type 1 diabetic patients. They aren't currently FDA approved for use in type 1 diabetic patients, but due to their mechanism have been used from time to time. So I think due to these incidences of DKA, we should probably back off on that use. And if you are going to use it in a type 1 diabetic patient, to make sure you're choosing the appropriate patient and educating thoroughly. So I think education is a big thing that's going to need to happen in both the inpatient and outpatient setting, is to make sure that we educate on hydrating and checking for ketones if the patient's sick or decreasing insulin dose, or if activity levels are changing, or insulin requirements are changing, that we definitely need to make sure to educate on checking for ketones. I think that we also just need to be cautious when we are decreasing insulin dose in patients that are on SGLT2s, just because that's a lot of when the cases we're seeing when decreases in insulin dose were done. I think with surgery, as we're going to continue to find out more information about this, I think that we should make sure to stop the medication at least 3 days prior to surgery due to its half-life and how long it's working. I think if we stop at least 3 days, and it might be longer than that, and not to resume therapy until the patient has started back on their normal activity, their normal medications, and their normal diet after their surgery. And another thing is just for emergency department personnel to be aware of this euglycemic decay, because with this high NIGAP metabolic acidosis and the patient has symptoms of decay but a normal blood sugar, it can be very confusing. So making sure that personnel in the ER are aware of this, and so we don't chase the rabbit too far before we come back to the conclusion. So that's what I found on euglycemic decay with SGLT2 inhibitors, and I'll be happy to answer any questions. Okay.
So do you think any part of this is the unavoidable consequence of infections?
Unavoidable consequence of infections? I think definitely a lot of it was infections. In a lot of the FDA cases, they reported that infection was the cause of the DKA occurring. So it is going to be something that happens. I think part of infections in type 2 and type 1 diabetic patients treated with insulin is that we just need to make sure to educate on testing for ketones, whether in the urine or the blood, to educate patients on that and the signs and symptoms so we can catch it early. Because in the patients that had the recurrences in that one case report, when they had the recurrences, they had educated the patients on how to treat, and they actually didn't have to be readmitted. They were able to treat at home. So if we could educate on, if you do see ketones, to hydrate and make sure you have some kind of carbohydrate source and still give insulin. So I do think part of it is just we're going to have infections. Yes.
So how often do you use your practice recommend checking
Yeah, so she's asking how often do we check ketones in practice and when should we check ketones in practice, especially on these medications. Generally in type 2 diabetic patients, I've never recommended checking ketones because it's just so uncommon in type 2 diabetic patients. So I would never recommend it in a type 2 patient unless they were on this medication and on insulin, because that's mainly when we've seen it. And a type 1 patient, I think the education for them is educating on 6 days, ketone management, as well as any other, I guess, infections and signs and symptoms, just to check ketones on those times. I don't know that it has to be a daily thing, even in patients on SGLT2 inhibitors, because the incidence is so low. Some studies have reported 0.01% out of very large populations. It's still a very low incidence, but something to be aware of. Yes.
The majority of the patients that we see here in DKA are type 2.
Yeah, okay. All these medications are in general?
In general.
Yeah, so, I mean, DKA can still occur in type 2. It's just much less common in general, I guess. I guess we just don't educate about it as much in type 2. So.
You see the same thing as Jeanna.
Wow. Any other questions? Thank you.